Nearly 1 in 3 Arizonans over the age of 65 report falling each year, and in 2016, falls amongst older Arizonans were responsible for more than 42,000 emergency room visits, 14,000 long-term hospitalizations, and nearly 1,000 deaths. So hospital bills related to unintentional falls in Arizona annually total almost $1 billion. For many older Arizonans, falls can result in injuries that cause pain or limit mobility for the rest of their lives. But falling doesn't need to become part of growing older. As today's witnesses have made clear, there are a range of early interventions and technologies that can reduce the risk of falling and mitigate the consequences. So with that information, I'd like to ask our panel a couple of questions. My first question is for Ms. Cameron and Ms. Haynes. Earlier this year, Banner University Medical Center in Phoenix became the first hospital in Arizona to open an accredited geriatric emergency department. In this specialized department, older patients are cared for by nurses and doctors who are specially trained to detect and prevent falls. A dedicated pharmacist monitors all medications taken by a patient to prevent adverse drug reactions which may cause dizziness. Patients are given non-slip socks, and their belongings, food and water, are kept close to their beds so they don't need to get up. Practical and common sense approaches like this are extremely affordable and can prevent thousands of injuries a year. Yet, relatively few healthcare facilities have chosen to make investments in these initiatives. What more should healthcare facilities, whether hospitals, doctors' offices, or long-term care facilities, do to mitigate the risk of falls? And what more can be done to better incentivize healthcare providers to prevent falls?
Thank you for the question. One really wonderful opportunity that Maine Health is involved with is the Hartford Foundation, Johnny Hartford Foundation, and IHI initiative around age-friendly health systems, which focuses on the 4 M's. What matters to the patient, mentation, which would be depression, delirium, and dementia, mobility, and medications. And that would be, I think, my soapbox. I've worked with older adults in various settings for 40 years, is medication, not just review, reconciliation, and really deprescribing and some focus on that. So I think that is, there are 120 health systems now focusing on that initiative, and I think it's a wonderful opportunity for us to build on exactly what you're suggesting.
Yes, one recommendation that we have in our written statement relates to the hospital readmissions reduction program, where we really believe that second falls should be added as a falls hospital readmission reduction program measure to incentivize hospitals to engage in falls prevention efforts, either by offering programs themselves or partnering with community-based organization to deliver programs to their patients who are being discharged for falls. So it really incentivizes them to do some discharge planning around those patients who are being discharged who are at high risk for falls. And really engaging healthcare providers in those efforts, but also referring to evidence-based community programs.
Thank you. My next question is for any of our panelists, especially those who have experience working with rural communities. This year's Aging Committee report highlights an innovative solution to the challenges posed by unintentional falls from northern Arizona. The Northern Arizona Agency on Aging has an extremely successful program called CareNect that connects low-cost wearable devices for seniors. These devices can connect seniors to multilingual care coordination centers, which can call emergency services if they fall. CareNect also addresses the serious problem of social isolation. The coordination center and their trained staff are available day or night to talk to and connect seniors with local programs in the area where they can socialize. While many Americans can purchase services like this commercially, for seniors in rural northern Arizona, these devices were either unaffordable or unavailable due to limited broadband and cell phone coverage in many rural areas. The CareNect system was designed to reach seniors in rural communities, including our tribal areas. So northern Arizona seniors benefit from the innovative leadership of the Area Agency on Aging, but many other older Americans living in rural communities aren't so lucky. What are the unique challenges and risks faced by seniors living in rural areas with respect to falls prevention? And what efforts could this committee support to reduce the risk of falls for all seniors, no matter where they live?
So I would suggest that is a fantastic model that we should learn a lot more about. But I think one of the things we see in our rural areas, and it may be because Maine has some of the oldest housing stock in the country, is around home modification, so that people want to remain in their own homes for the most part. And they may not be safe or adapted for whether it's a grab bar or my younger sister had her knees replaced and the walker didn't fit through the bathroom door. I mean, so that would be an OT going in before some of those things happen. So I think that model and some of what we discussed earlier about, innovative grant funding to be able to replicate that, as well as taking a look at the home modification piece in rural areas.
Yeah, certainly transportation is a huge issue for older adults living in rural areas who are no longer able to drive themselves and may not have family members who can get them, whether it's to doctor's appointments or to some of the programs that we've been talking about. So looking at innovative approaches in rural areas to provide access to transportation is sorely needed.
Thank you, Chairman.